This is an interesting tumor because it's really sticking out there.
All right, so it's really time for the journey to begin. Today is the first day that I will meet face-to-face with my oncologist to map out our roadmap to my recovery. And I'm taking you guys along with me. I don't know how much of this I'll be able to record, but I will record what I can or update you on the end. So now I'm about to go downstairs, jump in this ride, and head over to Tripler Hospital. So let's go. Tripler Medical Center, Medical Hospital. Can't record in here, so I'll catch you guys in a minute. So apparently the cabbie dropped me off at the wrong entrance. Not his fault, he didn't know. But we're headed to the oncologist now. Luckily, I came early, just in case something like this happens. So you guys whisper a prayer, and I'll catch you in a minute. All right, so this has been kind of a whirlwind thus far. So apparently I wasn't supposed to go to oncology. I was supposed to go see the ENT first. So that's where we're headed right now. It's on the other side of the hospital. But luckily my appointment's at 9:30, not 9 o'clock. So, see you when I see you.
And can you remind me, did we get a PET scan scheduled for you already?
Yes, ma'am.
When's your PET scan?
If I'm not mistaken, I think it's on the 6th. Let me double check, because I have my schedule here.
Okay.
There's my actual schedule.
Oh, good deal. Good deal. Okay, so, this is today. You're seeing Dr. Wynn tomorrow. You got your PET scan on Thursday. I think this is a radiation consult on Friday. And I'm not sure what. Oh, we'll probably have you coming back next Tuesday to go over your PET scan and all that. Your anesthesia, your virtual appointment, and surgery on the trays. Good deal. All right. Okay. So to review, you had your biopsy done. Was it about 7 weeks ago?
It's about 7.
Okay.
About that.
How's your throat feeling since then?
It feels about the same, but I'm noticing a lot more mucus build up.
Okay. And what brought this to your attention initially?
I had just come back from vacation, and before I used to have tonsil stones.
Okay.
And I just thought it was tonsil stones again. But when it didn't go away, I'm like, maybe there's something going on, so I went to get checked.
Gotcha. Other medical issues that you have?
I had a heart attack in 2020.
Yeah.
Yeah.
And are you on a blood thinner? You are, aren't you?
I'm on
We talked about that.
aspirin, yes, but I haven't taken aspirin in, I guess it's been about 4 days now.
Okay. Was that in preparation?
Yes,
for
in
all this?
preparation for this.
Do you have a cardiologist?
No, I don't have a cardiologist.
Okay. When was the last time you were kind of checked out by?
They normally every 3 to 4 months they just do blood work just to check.
Is that your primary?
Yes, my
Or
primary.
checking like your cholesterol?
Yeah,
and things
checking
like
my
that?
cholesterol and things of that nature. As far as actual seeing a cardiologist, I haven't seen one, and I guess it's been 2 years now, 2.5 years now.
Okay. Allergic to anything?
No.
And do you smoke or have you ever?
I used to smoke. I smoked for over 20 years.
Okay. And family history of cancer?
None.
Okay. Allergic to anything?
No.
Okay. And besides the heart attack, high cholesterol, any sleep apnea?
Yeah, sleep apnea.
Other major medical issues?
No.
Okay. All right. Take a look here. So, help me remember that I do want you to have a thorough medical clearance before surgery. There are a couple ways to do that. Sometimes we have the internal medicine doctors see you and do an EKG and things like that. Sometimes we have kind of our more senior anesthesiologists do it.
Okay.
But we need to make sure with your history that there's not some other thing that needs to be done to optimize you for surgery. So sometimes they'll say, oh yeah, you're at 20% risk of some sort of cardiac event with surgery. Good idea to get a stress test or something like that. So,
okay.
Yeah, just remind me.
No problem.
Okay, take a look at this guy. This is an interesting tumor because it's really sticking out there. You looked back here. You can see this thing. Yeah. But I feel like I can see a lot of it. And dental. Don't answer this question now. Relax your tongue, let me push your tongue around. Did we get you a dental appointment too?
I think that.
We talked to the dentist about you, but I don't think I saw it in your paper. They're usually pretty good about accommodating our patients for us. All right, this is the part where you're not gonna like me, okay? I'm gonna put my finger on this.
All right.
Probably make you gag. I apologize. You're doing great. Okay, good. Thanks. Can I feel your other side? Just making sure you did not have your tonsils out as a kid prior to that.
No.
All your native tonsil tissue should be there.
Yes.
I'm gonna feel your neck. Did Dr. McDonald put a camera in your nostril before?
Yes.
I'm gonna do that again. Is that all right?
Yes, ma'am.
I've got nose spray. You can. This is Dr. Gaius.
Hello. Nice to meet you.
She's my chief resident. Do you prefer to have or not have the nose spray? Has a terrible taste, but it does make the camera a little bit more comfortable.
Whatever makes it more comfortable.
Okay, we'll do that.
Do you need a scope?
That would be great. Would you like getting some spray as well?
Yeah. Okay.
Yeah, like we talked about over the phone, there's a couple different ways that we can do this, kind of the sequence of things. Do you want
Okay, I can set up the camera.
I'll do this. Why don't you put a light on and look in his mouth? Do you mind if Dr. Gaius takes a look?
No problem.
These are going to be for the spray for your nose. So that's all out.
And so this has a terrible taste. It will numb and decongest you. All right. I'm gonna spray this side first. 1, 2, 3, sniff. And we'll do the other side. 1, 2, 3, sniff. Sorry about that.
It's all right.
She was right. Bitter?
Yes, very bitter.
Okay, I'm gonna raise you up just a little bit.
All right.
Oh yeah. Well, I didn't have to look very hard, huh?
Yeah, it's very exophytic.
It's very exophytic. And explains your muffled voice as well.
Yeah.
Is that a good thing or a bad thing?
Yeah, when you take care of a tumor, if it is kind of sticking out, it's usually easier to get around versus if it's
Like
big but kind of
buried.
buried. So like we talked about, my best assessment of how I'm going to be able to get around it is probably going to be when you're asleep, right?
Yes.
When we put our retractors in. We'll go over that more in a second here.
All right.
For
Grab my phone.
this part, if you could bring your shoulder blades, off a little bit. Great. Have you opened for me? Oh yeah, thanks.
Okay.
Good to go. Okay. And then I'm gonna go down this nostril here.
Worst part coming up right here. You're doing great.
Feels like a COVID test.
Breathe through
That's
your nose
exactly what it
for
feels like.
us.
Yeah.
I know it's easier said than done. Good. Yeah, it's blocking off your way. Extend a little bit.
Yeah, it's
It's
hard
like
to
an
know if
obstructive
it's. I think
thing.
it's just more prolapsing. You know what I mean?
Yeah,
Rather than
rather than extent.
yeah. I don't think you're going to be
It
able to
doesn't
tell
look as
until you,
ulcerated down
Yeah.
there.
you're going to be able to really know until you do a DL.
Yeah.
All right, so the missing pieces that we need are one, to get that PET scan, right? A PET scan is essentially a cancer scan. A CT scan shows us how tissues look. A PET scan shows us how tissue's behaving.
Okay.
So things that are taking up more sugar, you get sugar injected into your veins, and things that take up a lot of sugar are indicative of, in this context, a malignancy. So we'll see that tonsil light up really, really bright, and then
Did you get it?
so the first thing we need to do is rule out any metastases anywhere else in the body,
Okay.
like in the lungs, because that changes what we're dealing with. But based on what we've seen so far, I don't have a high suspicion that you have cancer that's spread anywhere else. We can see on the CT of your neck that it doesn't look like there's any lymph nodes involved in the neck. So that makes it kind of unlikely that it's gone anywhere else, but we'll get that done. And as long as that doesn't show anything surprising, then we, go down this route of what's the best way to treat, like we talked about over the phone. Primarily surgery versus primarily non-surgery. And in overall, whether you choose primarily surgery or non-surgery, outcomes are about the same. A very high chance of surgical cure, and we're talking over 85%. Living at least 5 years and kicking this thing. So then you say, okay, well, what is the treatment option that offers the patient the best quality of life, right? The fewest side effects. When you talk about surgical side effects, there are potential risks to nerves in the area, because we're often removing lymph nodes, and that I would plan to remove your lymph nodes, because we know that cancers in the tonsils usually drain to the lymph nodes on the side of the neck, and so sort of as a matter of course we take those out. And then the actual removing the tumor in the back of the throat, with that comes potential changes to voice, speech, and swallow. And then there are the potential risks of bleeding after surgery, which is something we take pretty seriously, because if you have bleeding in the back of the throat, it can cause an airway issue, and it can be, potentially catastrophic. So we mitigate those risks as best we can, and we try to pick the patient that would have the least quality of life issues with the primary surgical plan. And we try to do it in patients where we have a fair amount of confidence that we're going to get around the margins of the tumor, get clear margins, not leave tumor behind, and hopefully not to need to give the patient chemotherapy. So indications for chemotherapy are if you can't get all the way around the tumor and you leave some tumor behind, well then that's one of our indications for adding chemotherapy to the post-surgical regimen. Or if you find lymph nodes where there's so much tumor in the lymph nodes that's actually growing out of the lymph nodes, then that person is kind of like on a highway to chemotherapy anyway. So we use those two things to decide, okay, if none of those things are very obviously present in the beginning, and if the patient's pretty healthy otherwise, they can tolerate a surgery, etc., they might be a reasonable surgical candidate. And the benefit is, well, you can sometimes give the patient a lower dose of radiation, which means that they have less stiffness and fibrosis. That's the big issue with radiation, causes a lot of stiffness and fibrosis, and might be able to avoid chemotherapy. For a patient who, they're not a good surgical candidate, so they've had 4 heart attacks, or they have a very, very small jaw, and I look in their mouth, I can't see the tumor, or it's a very large tumor, I feel like I can't get around it, then those patients, they go straight to the non-surgical therapy, which is radiation and chemotherapy. That's a 7-week course, and it can be tough. The side effects from those tend to be more delayed. So everybody has speech and swallowing issues, but in the surgery patients, the speech and swallowing issues are like right there up front, right? And tend to get maybe a little bit better over time, whereas with the radiation and chemotherapy people, those side effects are maybe a little bit slower to manifest, but then they kind of get worse over time. One of the biggest risks of doing a tonsillectomy for cancer, and we'll talk more about this after we do the direct laryngoscopy and make sure that we feel good about doing a radical tonsillectomy. But in some of the rooms we have a picture of a tonsillectomy. This isn't one of the rooms, but you go through the mouth. You take the tonsil, and then you also, there's a muscle that goes around the back of the throat. It's a swallowing muscle. It's called one of the constrictors. You take out not just the tonsil, like you would do in a 5-year-old who snores, right? But you actually take out
part of the
muscle as well. So that changes the way you swallow. You remove a little bit of the soft palate as well. And so that can cause, eventually, usually that scars. But when you swallow, to keep air and liquid from coming out of your nose, your soft palate touches the back of the throat, right? In a normal person. Well, if you've carved out a bunch of that tissue, initially, a lot of people, and sometimes even permanently,
comes out of the nose,
will have something called velopharyngeal insufficiency, where you have a gap there and it can come out of the nose. So that is something that we try to repair primarily. We try to close it at the time of surgery. Most people, for a time, are going to have some insufficiency, some stuff coming out of the nose, and sometimes even permanently they may. And that's something that they, kind of come to terms with.
Now, what are we talking? Are we talking liquid? Or are we talking about solid foods? Okay.
Yeah. It's hard for solid foods to get up there, but a lot of the stuff that you eat that's solid, by the time you swallow it, it's very, it's almost liquid. Another major issue is the pain post-operatively. A tonsillectomy actually is one of the most painful procedures that we do, because everything that you do, breathing, speaking, swallowing, kind of involves that area of your body, right?
Yes.
Even just drinking water can be extremely painful, and it's that way for a couple weeks. A lot of times people they physically can't eat. So I usually start out by dropping a feeding tube in my patients. I put the feeding tube down the nostril and then just make sure that I have a way to get them nutrition, because you need nutrition to be able to heal. Some people surprise us all, and we can take the feeding tube out the next day. They're like, no, I got this, I'm swallowing fine. But some people, they actually need it in the whole time while they're healing. Some people down the road, whether right after surgery or in radiation, they need so much help with swallowing, they've lost enough weight that they actually need a feeding tube in their stomach, more of a permanent thing. And that's something that we kind of just wait and see how you do.
Okay.
I want you to feel like you have the space to ask all your questions, and I think it's a good thing that you talk with my partners, not just the surgery perspective, right? I want you to hear from the radiation doctor. When you go there, I want you to say, hey, what does radiation look like? How long is radiation? What can I expect 12 months, 5 years down the road after radiation, etc.? And ask them also, like, given your living circumstances, like, what if I need to get radiation, or I want to do only radiation and chemo, where would you recommend getting that done, because I'm like kind of at a transition point, etc. And same with the chemotherapy.
Okay.
We have a great team. So things for me to do, talk with the internal medicine doctors versus the anesthesia team to see how we can get you kind of all the boxes checked to make sure you're safe for surgery. And then circle back with the dentists. So the issue with the dentists is in people who have or are getting radiation, if they have any teeth that are compromised, those teeth need to be extracted before radiation. If you do it after radiation, it's a setup for all sorts of jaw healing issues. Your teeth look really good, so I bet that they're going to not see anything that needs to be done with. But it's always a good idea to have their stamp of approval. And if they saw something they were worried about, we would talk to you about, how do you want that handled. I've had a couple of people be like, nah, I don't want my teeth out.
Whatever saves my life, that's all I care about.
Okay. Yeah.
I got people to live for.
Yeah. Next question for you. How attached are you to your beard?
Very attached.
I'm not going to make any...
Does it need to go away?
I'm not going to make any demands. But when it comes to surgery and anesthesia, one very important part of putting a patient to sleep is controlling their airway, right? And the anesthesiologist does that by putting a mask over your face, and then they take their left hand and they grab your jaw and they shove your jaw up into the mask, right? And they create this seal, and they're pushing air into your face. In a person with a beard, that's really hard. In me, that mask is going to seal right to my face, and the air is going to go in. And one of the modifiable things that you can do,
shave my beard.
So you think about it, you pray about it, but if we are doing everything to optimize how things go when you have surgery, I would say that your anesthesiologist would probably kiss your forehead.
If he says shave my beard, I'll have to shave my beard.
It would make things easier.
But not to rebut what you're saying, but when Dr. McDonald did the biopsy,
no issues?
No issues.
Great.
And when I had the heart attacks and they did the surgery, I had a beard as well then.
It is absolutely your prerogative. My job is to think about all the bad things that can happen. And so there's a little bit of, neurosis with me. I've seen enough tonsil bleeds and bad airways and stuff that, you know, I think about all the time. What can we do to
minimize,
kind of safety-proof everything? So obviously you can't make everything perfect 100% of the time. But if you had 100 anesthesiologists in this room right now meeting you, 100 of them would say, if you shave your beard, it'll make my life easier. You can also wait until you talk to the anesthesiologist. It's something you can do the night before surgery. And if they look at you or talk to you and say, hey, no, you know, you're going to be fine, then keep it.
Well, ladies and gentlemen, the appointment is done, and I'm about to head back to the hotel because I got to check out and head to my other hotel that I booked. Yeah, it's not gonna be an easy road, but I'm built for this. I'm built tough, so we'll get it knocked out. And I'll catch you guys once we get back to the hotel. We'll talk about it in a minute. So after a long morning and not eating anything for breakfast, I had to order some food. And I ordered Panda Express. I don't know what it is, but the Panda Express here in Hawaii tastes different. It's not as good. It's like it's missing something. But anyway, as you guys see in the video earlier, the appointment with the oncologist went well. We basically mapped out the road ahead. They're going to have to cut me. Actually, it's on this side. Cut me from here down. I'm gonna see if she can hit my. No, she'll cut wherever she cuts. But they have to remove lymph nodes to make sure that the lymph nodes have not been affected by. Let me turn this down. Haven't been affected by the cancer. And they're going to remove any lymph nodes that could have potentially been affected by the cancer to ensure that I have the best opportunity to recover from this. And then they're going to do the tonsillectomy, which basically is a tonsil removal. They're going to remove the tonsils or tonsil and some of the tissue behind it that could potentially be affected, just to give me the best chance of recovery. Once that's done, then I'll either have to have chemotherapy and radiation or one or the other. Won't know until I talk to the radiologist, which I have an appointment with them tomorrow, I believe. Don't know if I'll take you guys along with that on that appointment. Oh, I lied. Yeah, I'm lying. I'll probably take you guys to that appointment as well. I'm going to record as much of this process as possible and share with you all as much as I'm willing to share. Like I said, some of the nuances or some of the other things may be a little personal to me, and I won't reveal everything. But enough enough that you guys will get the information you need in the event that you yourself are going through cancer or chemo, or you know someone who is. But anyway, I'm getting ready to go ahead and polish this food off. I don't know what it is. It tastes different for some reason. But anyway, let me go ahead and knock this out so I can figure out what I'm going to do with the rest of my day. And I will catch you guys on the next video. Make sure you like, share, comment, subscribe. Click that post notification bell, turn it to all so that you know when I drop a new video. With that, we're out.